Onc Live Insights is a video editorial program produced by Onc Live.
We've recently used Panobinostat in combination with bortezomib in a patient that had a prior transplant, had prior induction therapy with RVD, and then had prior lenalidomide maintenance, and was progressing. There was a couple of options in that patient to discuss. Obviously, we couldn't use the ASPIRE data or the ELOQUENT data in combination with Revlimid and elotuzumab or Revlimid plus carfilzomib because the patient was Revlimid refractory at that point in time. But there were a couple options to discuss, including use of Velcade retreatment in that patient, Velcade Panobinostat based on the Panorama 1 data, as well as the Endeavor data with a higher dose of carfilzomib. Now, it was very interesting. When you talk with these patients, there's a unique dynamic that comes in, and the patient will state that they feel comfortable with prior bortezomib, they know what prior bortezomib is, and so they want to use all of their therapies before they move on to their next line of therapy. So I think that really resonates with patients when they want to feel comfortable with what they're doing, they're nervous at that time, they're relapsing, and there's a certain degree of comfort and there's not a new learning curve. And so then the use of a Velcade-based therapy becomes very appealing to these patients. And in that setting, this combination of Velcade plus Feridac becomes ideal because now you're really maximizing Panobinostat as well as bortezomib. I think that's one of the key messages here is that in today's era, as we move forward in myeloma and novel therapies, we really have to understand strategic sequencing and maximizing Panobinostat. So how are we going to get the best benefit from Panobinostat as well as bortezomib? And in this setting, we're able to improve the progression-free survival from 4 months to 8 months. So now the patient gets 12 months of benefit from combination therapy, and you can really maximize both therapies. And now you still have not used carfilzomib or pomalidomide in that setting, so you can still use those in later lines of therapy or in different combinations. But I think that's going to be the key, and I think that really resonates with patients as well, as they feel a degree of comfort with the therapy that they've already been exposed to. And then I think there's also some benefit that comes with the use of sub-Q formulation that makes it easier for patients coming in once or twice weekly as necessary. So in this patient in particular, that concept resonated and was treated with bortezomib and Panobinostat with a great response to therapy. And again, with the use of once weekly bortezomib and sub-Q, tolerated very well with minimal side effects. For this patient, we continued the combination of Velcade and Panobinostat for approximately 11 months at that time. Now, the nice thing is that, different from a clinical trial, we can take breaks in therapy. And so this does allow for patients when they're on therapy, and so, during Christmas time, he's able to take 3 weeks off and go enjoy family or travel. So we did incorporate those breaks in there and allowed him to maintain his quality of life, because I think that's important as well.
I remember very well a lady of 52, 53 years old, diagnosed of multiple myeloma 6 or 7 years ago, and she received bortezomib-based combination in the upfront setting, followed by autologous stem cell transplantation. But this patient relapsed very early after autologous stem cell transplantation. And this is a poor prognostic factor. So at the moment of the relapse, this patient was included in a trial with lenalidomide-based combination. Patient responded very well, but the duration of the response was very short. And although this patient achieved partial response after the 4th cycle, after the subsequent 6 cycles, progression disease was observed. So at that moment, this patient was possible to be included in the trial with Panobinostat, bortezomib, and dexamethasone versus bortezomib and dexamethasone. And the patient accepted to be included, and she started the treatment. She achieved a complete response, and even immunophenotypic complete response, so the minimal residual disease was negative in the bone marrow. She received the 8 planned cycles of bortezomib dex plus Panobinostat, but as the quality of life was perfect, the tolerability was very acceptable, so we decided to continue with the Panobinostat single agent. Now, I think that 5 years later, this patient continues receiving Panobinostat single agent.
We've done a number of clinical trials with Panobinostat, including sponsored trials and investigator-initiated trials. And one of the ones we found most interesting is a study where we've been exploring the use of Panobinostat in patients who've really had a suboptimal response to their frontline therapy. So these are younger patients who've had bortezomib-based induction. They've then had high-dose chemotherapy but failed to achieve a complete response. And we know that that in fact predicts for shorter progression-free survival and shorter overall survival. So in that context, we've explored whether switching to a different class of drug entirely, that is a HDAC inhibitor, can induce further depth of response. The data that we have and which we've presented here for the first time suggests that about 50% of these patients will get a further reduction in tumour burden. And we've had a couple of patients who've gone into complete remission and have now been on the agent for 18 to 24 months, maintaining those sorts of complete remissions with relatively acceptable toxicity. And the expectation is that the response that we've achieved with these newer agents will be quite durable. There's one lady in particular who presented with terrible skeletal disease and was quite refractory to her bortezomib-based induction, went into autograft really not achieving a partial remission, and she now only has immunofixation-positive disease in the context of post-transplant Panobinostat. So that response, I think, has been quite disease-changing for her, and it will be important to try and understand which patients will achieve this benefit from this class of agent, but we'll need to study that further.